Next.
Okay, then we switch over to the next.
Next, Jitendra Nenumal Jathani. He speaks on effect of DIMS lenses in halting the progression of myopia, not responding to LCA eye drops.
So this is just to tell that I am a key member in SLR Private Limited for Stellist, which is not DIMS. So why myopia progresses? There has been a load of literature in last, I think, 1 decade. There have been a lot of work on why exactly myopia increases in children. So one of the key factors is that near work causes peripheral hyperopic defocus, and another key work is on the altered dopamine release. My talk is on both, so I will be combining the two things. At this point of time, we all know that low concentration atropine is at the basis of treating myopic progression. One of the landmark studies was ATOM-1, which was published in 2006. And since then, we know that it works for myopic patients, myopic children for progression. But it is a harsh reality that almost 20 to 50%, depending on which literature we read, there are a number of patients who do not respond to low concentration atropine. And one of the possibilities is to increase the concentration. And second possibility is to give a DIMS lens or a Stellist lens. Now with this background, we did a study to find out the effect of myosmart lenses or DIMS lenses, as they call it, as an addition to low concentration atropine eye drops on myopic progression in children who are not responding to 0.01% eye drops. We selected 10 children. This was a non-randomized single-arm interventional study. The glass power was increasing more than 0.5 diopter per year, and the primary endpoint was to see the progression at the end of 1 year. So at the end of 1 year, the mean spherical equivalent was 3.9 diopters. Pre-atropine progression, before starting the atropine, was minus 0.76 diopter every year, which reduced to 0.68 post-atropine. So atropine was working, but not as much as we would like to. And then post-DIMS, the mean progression was 0.39 in total 10 patients. And if there were 2 patients who actually did not respond to DIMS, they were still increasing. And so the patients who responded, the response was quite good. So we all know that low concentration eye drops are safe and very efficacious at this point of time, but there are a good number of patients who do not respond to low concentration atropine. The dose can be increased, or we can alternatively prescribe these peripheral defocus lenses. What is peripheral defocus lenses and how do they work? So DIMS is defocus incorporated multiple segments. I showed the picture. There were multiple segments in that were plus 3.5 diopter, and these defocus segments are incorporated in the glass, leaving central 9 millimeter clear of anything. This all theory has started because of the publication by Earl Smith, which was published in 2009, saying that it is peripheral retina which is responsible for growth of the eye and not central retina. He has got wonderful article. He has followed up it in 2010, 2013, multiple articles on this. So how does DIMS work? This is the picture. What it does is those peripheral 3.5 diopter lenslets or defocus incorporated segments, they make a myopic defocus. This is the myopic defocus, and that is how they halt the progression of axial length. There have been articles starting from 2020, and then there was a recent final report of 6-year follow-up where they had multiple groups in patients only on DIMS with single vision, patients who wore single vision for 3.5 years, and then DIMS, and then there were only single vision patients. So what the conclusion was that DIMS glasses do reduce the myopic progression, and there is no rebound effect. In our particular work, we tried to show that we added this DIMS lens. So it was not a primary DIMS lens study. It was used as an adjunct. I mean, it was added to low concentration atropine in patients who are not responding. So this is clearly different from what has been studied across the globe. We did the peripheral refraction of our patients, and we found that they indeed had some hyperopia in the periphery. So basically, peripheral refraction would be 22 degrees temporal and 22 degrees on the nasal side. The refraction differs, and our study is unique that we prescribed these glasses in patients who were not responding to atropine. They were in conjunction with low concentration atropine. So the point is, it's opened new possibilities for patients who are not responding. Despite giving atropine, if they are still progressing, we can prescribe DIMS lenses, and that is the conclusion. Thank you so much.
I have one question, Jitendra.
Yes, ma'am.
When they did not respond to 0.01%, did you increase the concentration?
Yeah, so when they did not respond means they responded, but not as much as we would like them to. So we increased the concentration, as you said. We increased it to twice a day.
Oh, you mean you increase the dosage?
Yeah, not the concentration. Because it is not currently available. So we will have to formulate it.
Okay.
But they did not respond to 0.01%.
And you added DIMS to it?
We added DIMS. We did not withdraw them from atropine.
Okay.
Sure, your number of cases are very less, 10.
So
In other
DIMS
studies, there is a more number. What
No.
number?
So this is one of the first studies which we are talking about. DIMS lens costs around 15,000 per pair. So it's pretty expensive. So the number is low, and this is one of the first works in India. It was launched 2 years back. So because myopia, you have to follow them up for a very long time, and we wanted to do it. Honestly speaking, this is not our first line of treatment. We treat them with atropine because obviously we are in a cost sensitive country. So we treat them with atropine, and that is the reason we do not have any patient on primary usage of DIMS to compare. So these are all patients where atropine did not give a measurable response or as good response as we would expect. We added the glass to them.
Sir, in the OPD, can we make out the difference between this lens and the other lens?
Yeah, you can make out. I can show you the lens. I mean, this is a free paper session, so but I have the lens. I can show you the lens. You can make out. You can put a torch, and you can actually see those segments. Yeah, it's.
And just one observation I would like to make, because I was in the US recently, and there one of my son's friend's daughters was on on low concentration atropine, and suddenly her pupils dilated, and you know how it works in the US.
Yeah, they will become very scary.
They went to ER, and the physician didn't have a clue
what is wrong
of what is happening. And as soon as someone mentioned it to me, I said she must be on some drops.
Yes.
She has to be on some drops. And then in the evening they brought her to show me, and the first question I asked was, what are you using? And she was using higher concentration.
That happens, madam. We prescribed 0.01%. Patient thought that, this is 232 rupees. I will get atropine from somewhere else. Got atropine 1%. Called up at midnight that, you have given the drop, doctor, and the patient is not able to see. I was putting 1%.
Jitendra, what was the side effect of doubling the dose? Means twice daily.
There was no side effect.
It didn't work.
It didn't work, but there was no side effect.
Side effect means the patient's losing accommodation problem or...
No, sir. There was no side effect. So actually I have a couple of papers on doubling the dose. So there are, 30% of the patients would respond to doubling the dose, and 70% would still not respond to doubling the frequency.
And another point I would like to highlight here is, because since you are talking about low concentration atropine, is that many of our own ophthalmologist colleagues who are not into pediatric ophthalmology are not prescribing atropine, because some of my patients have told me ki I went to someone else after you told me, and they didn't say that you should put atropine.
Glass is there, madam. If you want to see the glass, they can see the glass.
We have to accept new things.
Yeah, actually, once we are after an age, it becomes difficult to really trust the medical reps, because like DIMS also, it's a market-driven technology. Yeah. The cost is 15,000. We understand that we have to accept it, but we do not have to follow it, that we start primarily on DIMS and not give due credit to cheaper drugs or cheaper things.
Right. Thank you so much.
Okay, ma'am. Thank you.